Hello, everyone. Welcome to our webinar on Medicare 101 featuring Kerry Quick. My name is Eric Danielson. I'm the Communications and Client Services Administrator for AFP. We are going to be recording this webinar and future webinars as well, and this probably lasts about 30-40 minutes at most, and we will have a Q&A session afterwards. Once we start the Q&A session, we will stop the recording for this video, and the video for this will be posted on our website within the next couple days. So in order to make sure this runs smoothly, we have muted everybody's mics and disabled their videos on entry. So if you do have questions, you can post them into the chat. So if you look at the screen, you can enable the chat by hitting the little chat button on the Zoom menu, and that'll open the window, and you can type in any questions you might think of during the presentation, and we will address them at the end. So if you also have any suggestions for future webinars, you can pop those into the chat as well. So with that being said, I will hand things off to Terry and Kerry.
Great. Hey, thank you, Kerry, for doing this. We really appreciate it. I know this is a topic that many people can get confused in, and there's a lot of moving parts to Medicare, it seems like, every year. So we really appreciate the opportunity for you to kind of go through and enlighten us on this subject matter.
Thank you for having me. And for those of you who are attending, first of all, thank you for coming. I'm sure that this is not the most exciting topic, but nonetheless, it's a necessary evil. And I apologize that my screen is not appearing very well. I was telling Eric and Terry, we're currently under construction, and because of that, our internet is wonky, so bear with me. The content will be the same whether you can see me well or not. Just very quickly, I always share this with people because I think it helps them kind of tie things together. My company, under a different name for many years, managed group health plans for smaller employers, which gives us a very unique perspective on Medicare. And frankly, we just started getting more and more calls from people within our groups asking for Medicare guidance. So initially, we got into this just in an effort to help. It wasn't long after we did that we saw how difficult it is to navigate. And we also started to realize that in many cases, it made better sense for people to move away from the employer plan into Medicare if they chose to work past 65. That's become far more prevalent today. Employer plans, retirement plans are not always what they once upon a time were. So the message we push out more than ever today is don't assume if you have access to an employer plan post 65, it's your best bet. It may or may not be. And people are funny and they'll say, really, I can still work for my employer and not use their insurance? Well, if you think that through, no employer is going to say, oh, please stay. We want you to continue to be a liability financially to us. So a little over 15 years ago, we decided to focus in Medicare. Today, we're truly the only company in Columbus who does what we do, and that we are completely focused in the Medicare market. We're independent. We work with all the major insurance companies. We're not wedded to any of them. Our ultimate role is to explain to people, and what we hope is plain English, what their options are when moving to Medicare. So that was my 5-minute commercial. And Eric, if you'd like to just go to the next slide, that would be helpful. And for those of you in attendance who might be part of state teachers, Ohio Public Employee Retirement System, any federal programs, we're typically not able to help you as the actual retiree, but we can certainly help your spouses if need be. As I just mentioned, we are independent. We're local. We think there's still a lot to be said for having a local presence in the business world, especially today when things have gotten so fractured. As I also mentioned, we're completely focused in Medicare. We don't sell 15 different kinds of insurance and claim to be Medicare people on Thursdays. This is what we do. And again, the local presence we think is very important. We are not fee-based. The only way we are compensated is if we ultimately file an application for coverage for someone. Next slide, please. So today what we'll talk about, it's very 101 as was advertised. We are not permitted, because it's an educational seminar, to get into any specifics about plans or who we represent in terms of insurance companies. Hopefully you'll walk away today with some better understanding of what Medicare is all about, what you might need to do next if you need to do anything, those kinds of things. We'll talk about the options for coverage very briefly, enrollment times, and of course we'll talk about costs because that's everybody's top of mind.
Okay.
Next
Next
slide.
slide.
Now, it's not uncommon for people to come into our office on a daily basis with a stack of material that they've been receiving over the course of, in many cases, more than a year. The marketing in the Medicare market is absolutely obnoxious. It's predatory as far as I'm concerned. The documents that you're receiving in the mail tend to use, or the companies, I should say, tend to use rather heavy-handed language, suggesting that you should have done something a year ago. Everybody's plan, of course, is touted to be the best in the business. It's all just marketing. And one of the things that we point out to people is, while we still live in a free country and we can buy whatever we want, until you understand the mechanics of what you're receiving in the mail, it may or may not be a good option for you. And that's our role, to take that really big pile and narrow it down to a very skinny pile in about 30 seconds, frankly. Doesn't take long.
Yeah.
What's interesting is Medicare has not changed a whole lot since 1965 when it first became a real deal. It's been tweaked along the way, it's been enhanced, but the major footprint has not changed a whole lot since 1965. The biggest misconception about Medicare is that it's mandatory. It is not. It's simply an option when you turn 65. Whether or not you go there depends on your circumstances. You're not going to be penalized if you don't move to Medicare. The only time penalties come into focus is when you cannot show that you've had ongoing coverage. So once again, we remind people, between the marketing materials, the awful advertising on television, and then of course all of the unsolicited commentary from your expert friends and family, it gets very noisy. We are regulated by CMS, the Center for Medicare and Medicaid Services. It's the ultimate watchdog over Medicare as well as us.
So, Kerry, does someone have to apply or acknowledge if they're not going to go on Medicare?
No.
They don't have to do anything.
No, and very briefly, and again, I won't get into details because it gets very weedy, but one of the types of insurance coverages that has become quite popular with employers over the years in an effort to continue to offer benefits and not have to extend prohibitive premiums has been HSAs, health savings account, high deductible plans. Very simply, you are not permitted to make contributions to an HSA when you become eligible for Medicare, unless you do not apply for Medicare or Social Security in any part. So there are times when we will guide people to not apply for Medicare Part A at all if their goal is to continue to work and make those HSA contributions. So to say that it's mandatory that you have to do something is absolutely not true.
Okay.
People defer Medicare on a daily basis. Not as much as they used to, perhaps, but certainly it happens on a daily basis.
Okay.
Let's start talking about what I refer to as alphabet soup. It gets a little confusing, but we try to keep it as simple as possible. Medicare in and of itself is made up of two major parts, Part A and Part B. Part A is what you fund in the years that you work via payroll taxation. So when people say it's free at 65, it is not. You've been paying for it all along. So for most people, but for those who may not have been paying into Social Security, for most people, as long as they have 10 years of work history, they will have funded Part A. So there is no premium at 65, but it certainly isn't free. Part B is actually outpatient. This is your doctor, your lab, typically anything outpatient falls under Part B. This is where the government does attach a premium. So while Medicare is not mandatory, as many people believe, just like an insurance company, it does charge a premium, and that's attached to Part B, and we'll talk about that a little later in the presentation. Together, A and B, and you'll see this again in an upcoming slide, together A and B, for the sake of discussion, represents an 80% plan with no drug coverage. So ultimately what I do, what my company does, is explain to people what their options are to address that 20% as well as prescription needs. Part C is the technical term for Medicare Advantage, which we'll also talk about. And Part D is prescription drug coverage. Part D is actually the newest part of Medicare. It came into Medicare in 2006. Next slide. So when we talk about options for coverage, there are in fact people out there who just have Medicare A and B. I certainly wouldn't recommend that, because while people will say, gee, an 80% plan's not bad, true enough, but there's no ceiling, there's no cap to the 20% that's not covered. And today that could be financial disaster given what things cost. And there are very affordable options out there, which we'll talk about, to address that 20% that's not covered. So in my mind, no one should be out there with just original Medicare Part A and B alone with no other coverage. There are many times when we can still do the math and encourage people to stay with their employer plan. We are not in the business to try to fix what's otherwise not broken. So if someone's employer plan is still pretty competitive and that person is going to work past 65, we will absolutely encourage them to ride that wave as long as they can. Same thing with a retirement plan. They're not what they once were, but there are still some good ones out there. And once we run the numbers and we can demonstrate on someone's behalf that staying with that retirement plan is their best bet, that's what we're going to advise. Now, when we get into VA coverage and federal coverage, that changes a little bit. If someone does have access to the VA, it may not be for full health care, but we do encourage that they might, for instance, pursue prescription help. Things are on the horizon to help with Medicare recipients going forward, but until that comes to fruition, drug coverage is a place where we spend a lot of time because it is such a cost driver. And when people have access to VA, that can be a huge, huge help. Generally speaking, most mortals, as I say, when they come into Medicare, have two options for coverage. It's either going to be a Medicare supplement with a separate drug plan, or a Medicare Advantage plan where drug coverage is typically built in. The word supplement, supplemental, unfortunately tends to be used as a catch-all term, but it's a very specific product, which we'll talk about next.
Okay.
As I mentioned earlier, together, hospitalization and outpatient, Part A and Part B, represents an 80% plan with no prescription coverage. That's known as original Medicare. And where we help people is to find those options to help them with that percentage as well as prescription needs. So again, it's either going to be a supplement with a Part D plan or a Medicare Advantage plan. Very simple. I usually get a laugh when I tell people that, because the marketing is so overwhelming and you get so much stuff. It feels as though you have 1,000 options, but in reality, you have two.
So what is a downside to Medicare Advantage?
Well, that's somewhat perception more than it is reality. What I point out to people is that both options cover the same things. It's not about coverage, because ultimately Medicare is in the background dictating what's going to be covered. It's more about how much you want to pay for it and when, and to some extent how much flexibility you choose.
Okay.
So the next slide we'll be talking about Medicare supplements, which for the longest time were the only option available to people to address the 20% not covered. Medicare Advantage is still, in the grand scheme, the new kid on the block.
Okay.
Medicare supplements, again, the word supplement tends to be used as a catch-all, but it's a very specific product. The technical term is a Medigap policy. These have been around as long as Medicare, well, at least since 1966 for the sake of discussion. These are private policies that you purchase from an insurance company. What they ultimately do is wrap around Medicare Part A and B and ultimately pay the 20% that's not covered. when you have a Medicare supplement, you are going to be paying more in monthly premium, and that doesn't mean it's better. That's the overarching misconception. What it does mean is that you're paying ahead of time. You're paying more in premium so as not to come out of pocket later in the form of copays and deductibles. And you are able to go wherever you choose, meaning you're not working within a network. So I suppose you'd make an argument that you're paying more for that ability to have flexibility. 10 years ago, that was a bigger deal than it is today. And we'll talk about the Advantage program. The networks on the Medicare Advantage side have gotten very, very broad. So that concern about being out of network is not what it once was. Nonetheless, if someone's end game, someone's goal is complete flexibility with no restrictions, then they're best served going with a Medicare supplement. And there are some other extenuating circumstances that would make supplements a better option. But you just need to be mindful that not only are they the more expensive way going in, your premiums, no matter who you're with, will increase each year. The older you are going into a supplement, the higher the premiums, etc. They are not including drug coverage as Advantage plans do. So if you go with a supplement, you will typically also elect a standalone Part D prescription plan.
Okay.
So some people need clarification on the fact that Medicare in and of itself does not offer coverage options. It regulates some of the options, but it does not offer coverage options. All of that is through private insurance companies. As I mentioned, Part D is the new kid on the block in terms of overall options. It came into existence via the Bush administration in 2006. Prior to that, we really didn't have drug coverage per se. Whether a person is using a Part D plan alongside of a supplement or where it's built into Medicare Advantage, it all works the same way. These companies are required to cover 2 drugs per category. They don't have to cover everything. It's a moving target year over year. During open enrollment, where we spend most of our time is in this world, because Part D prescription coverage can be a real cost driver for people. It's gotten somewhat better, but it's not perfect. Have to cover 2 drugs per category. They don't have to cover everything. I started to say the adjustment that people face when moving into Medicare is typically not finding a solution for doctor and hospital. That's easy enough. It's prescription coverage that can be a challenge.
So do you think, Kerry, with the new Inflation Act and the ability for them to lower costs potentially, or Medicare to more negotiate the cost of the prescription drugs, is that going to have any impact?
As I understand it, and full disclosure, I've not had the opportunity to do a deep dive on the language, but as I understand it, just having done a cursory review, that is only going to apply to about 10 drugs, not the entire playing field. So I'm not real excited about it, quite frankly, having been in this market for more than 15 years and seeing what brand name drugs cost. I mean, today, the average, and this would be a low average, actual retail cost of a brand name drug is about $600 a month.
Wow. Yeah.
So it's going to take a lot to move that, especially knowing on the other side of it why the cost is transferred to the consumer. I mean, when you think about all the hoops that these companies have to go through to get FDA approval and the clinical, things that go on for 10 years in terms of finally getting something to market. And I'm not saying that's good or bad, but that's reality. So there are some other things that are on the table that we hope will be impactful, maybe not so much just with the direct costs, but extending the donut hole, for instance, which we'll talk about, so that people will have a cap in annual drug coverage. There really isn't one now.
Okay. All right. Good to know. Okay.
Medicare Advantage plans. Medicare Advantage plans, and this is somewhat of a watered down story, but they came into the market when the government decided to outsource the payment and management of Medicare claims to the private sector, which gave rise to Medicare Part C, again, more commonly known as Medicare Advantage. Part of that outsourcing involves compensation. Every time someone enrolls in a Medicare Advantage plan, the government pays that insurance company a stipend, if you will, to pay the claims so they don't have to. Therefore, they're a lot less expensive than Medicare supplements. Many of our more than half of our clients actually are in Medicare Advantage plans, and the vast majority of those folks are not paying any monthly premium at all, but for what they pay for Part B. Everybody has to pay Part B premium regardless. When a company offers a zero premium Advantage plan, what they're saying is between the subsidies they're receiving, plus your cost sharing, because with Advantage, you're paying co-pays. What they're saying is we're in a position to offer this to you at no additional cost, meaning on top of Part B. Advantage plans?
Yeah, they're not able to flip back to the other plan though, right? Once you're in Advantage, you are there. You're not able
No,
to
not necessarily.
Okay.
Not necessarily. That's a great question. When you first come into Medicare, both options are available with no medical underwriting. You're guaranteed either option. The law says you have 6 months from your Part B effective date to be guaranteed a Medicare supplement. If you apply for one beyond 6 months, you will be asked medical questions. So the message to people is if you think a supplement is the way you want to go, the time to do it is when you're first eligible. But to say that if you start with Advantage, that you can never go to a supplement, not necessarily, but you just have to be mindful that you will be asked questions.
Okay.
And in most cases, most companies will just decline you. I've only seen one company in 15 years rate people up, meaning charge a higher premium, and it's significantly higher.
Okay.
Advantage plans are typically HMOs and PPOs. With a PPO, preferred provider organization, you have both in and out of network. You're best to stay in network in an effort to keep your costs down. But if you had to go out of network, you could. In an HMO, health maintenance organization, you're either in network or you're not. There is no out of network provision. Advantage plans typically include drug coverage. We often call these plans one-stop shops, where you have one identification card that addresses doctor, hospital, prescription. So once again, just flipping back and forth, when you have a supplement, you're paying ahead so as not to come out of pocket later, and arguably paying more for flexibility. In an Advantage plan, you're paying little, if any, premium, but you're paying as you go with co-pays. And you are working within a network, which have gotten very broad over the last 10, 12 years for sure.
Okay.
One of the other, before we start talking about Part D, one of the other misconceptions about Advantage is you can't travel with them. That's not true. Whether you have a supplement or an Advantage plan and you're traveling within the United States, you have 24/7 emergency coverage. And typically it is an emergency. Most people don't go on the occasional vacation with the idea that they're going to go to a doctor on purpose. Medicare does not cover you out of the country. Many people are not aware of that. If we know that our clients are traveling abroad, we absolutely encourage them to purchase travel insurance. You may have...
How about the Advantage? Are you covered overseas for Advantage plans?
There are many Advantage plans that will have some emergency coverage, but we still recommend that people purchase travel plans, because what you're going to get through your health plan is bare bones ER. A travel policy, on the other hand, would help you get out of the country if necessary.
Okay, sounds great.
Eric, you can advance a couple more here. It just fills in. Yeah, I think that's the fill-in. Okay. As I mentioned, prescription drug coverage has been in the market since 2006. It's probably the part of Medicare that's not well understood. And of course, it has a lot to do with the fact that whenever the government is regulating something, they always make it wildly confusing. Essentially, every year there's an amount of money that's established for people in Medicare in terms of drug costs. This year, in 2022, the chunk of change, if you will, was $4,430. That amount of money represents your copay plus what the insurance company is kicking in to make up the difference. So when you fill a prescription, you're getting charged for the full cost of the drug, not just your copay. The full cost of the drug comes away from that $44.30. If you exhaust that amount of money, you now move into what we affectionately refer to as the donut hole, the coverage gap. This is good news, bad news. The good news is there was language in the Affordable Care Act that spoke to the eventual shrinkage, not closure, shrinkage of the donut hole, and that took place between 2019 and 2020. 12 years ago, if you went into the donut hole with a $600 drug, you paid $600. Today, you'll pay 25% of the cost of that drug. So it's not perfect, but it's a whole lot better than it was. Between what you come out of pocket in the initial level, that $44.30, and what you come out of pocket in the donut hole, you can be out of pocket up to a little over $7,000, as you see. If you go through the donut hole, now insurance kicks back in and your drugs are covered at 95%. So for some people, this is a silver lining because their drug costs fall, right through the floor. However, they came out of pocket a lot of money to get there. Now, one of the things that's been proposed is that there'll be a cap placed on drug coverage, because right now there is none. So there are people, given the cost of really, really fancy drugs today, you can go into the donut hole in about a month and right into catastrophic, and then continue. Yes, you're only paying 5% of your cost for the remainder of the year, but that could still be a very large number depending on the cost of the drug. The proposal is to put a cap on that. So we spend an awful lot of time encouraging people to have very candid discussions with their doctors. Try to get as many of your prescriptions in generic form as possible. It isn't always possible because the cost differential between brand name and generic is incredible.
Yeah, it's huge.
Enrollment periods. I stress the importance of starting this process as soon as you can. Certainly utilize the 3 months before your 65th birthday as best as you can. That's your due diligence. That's when you can get your ducks in a row and figure out what you need to do next. Right now, it's August 26th, and I'm chasing after people who did not do that, and now it's the 11th hour, and we need to get them covered by next Wednesday. Don't do that to yourself because it's crazy, crazy stressful. Essentially, you become eligible for Medicare 3 months before you turn 65, and it's not about your actual birth date. It's about your birth month. So if you were born on June 15th of 1958, your actual eligibility begins March of 2023. And your effective date for any Medicare coverage would be June 1. So ideally, in a perfect world, which we don't live in, if people are going to move to Medicare, ideally they move to Medicare the month they turn 65. Right now, it gets a little bit dicey when you try to apply for Medicare in the 3 months following your 65th birthday. For whatever reason, and there's no explanation, Social Security can arbitrarily bump out your Part B effective date, which can render people with no coverage. So on one hand, they say you're eligible 3 months before, the month of, and 3 months afterwards, but they don't make it clear that in that 3 month window following, they will bump out dates. So either go to Medicare when you're first eligible or wait at least 4 to 6 months later because it gets that complicated. If you defer Medicare because you've deemed that your employer coverage is reasonable, or it could be you have a younger spouse on your plan, so you really can't move to Medicare because you would otherwise render that spouse with no insurance. But now you're ready to retire. We encourage you to allow 60 days. This says 3 months, but my experience has been Social Security doesn't do much beyond 60 days in advance. When you defer Medicare, the burden is now on you to show the government that you have had ongoing coverage. So there are documents that you have to submit to Social Security showing that you have had coverage. And now you're at the mercy of the government. So it's a process that can be rather cumbersome, because once you submit the documents, then you have to stay on Social Security to make sure that they process your Part B application. It just gets more complicated because they don't have a real strong sense of urgency as far as getting things processed. They live in a world where It's just, and in defense of them, I mean, like all industries, they have staffing issues currently. They just literally reopened between April and May of this past summer. So it's still a little rocky in the Social Security world.
So, Kerry, if you had that situation where you have a younger spouse or you have kids on your employer plan because they're under, let's say, 26 still, and they delay taking their Medicare maybe for a year or two, does the supplemental side go up while they're waiting? The cost of that?
The premiums, yes. The older you are going into a supplement, the higher the premiums, for sure.
Okay.
Absolutely. But again, it's not the go-to option that it once was. People are understanding Medicare Advantage a lot better, and there's never any age band correlation with Advantage and premium. If it's a zero premium plan, it's going to be zero whether you're 65 or 70 or 80.
So that way it would favor, if somebody has to wait a few years just due to their situation, that the Advantage plan would probably be more favorable than going the traditional route.
Financially, what we encourage people to understand is, as I've probably already said 3 times, both options cover the same things. It's not about that. It's about how you want to manage your out-of-pocket costs and when, and the flexibility issue a little bit. But ultimately, it all comes down to utilization. At some point, you're going to use your coverage.
Yeah.
So what I encourage people to do, for instance, when they enroll in a zero premium Advantage plan, is keep putting money away somewhere so that when you do have utilization, you have a fund to go to for those co-pays. I know that our clients in Advantage plans can do the math all day long and demonstrate that they've saved a lot of money over the years in premium, but you have to plan.
Yeah.
If we get calls from our current Advantage clients who are now making some noise about their co-pays, they're usually 75, 80, they're going to the doctor more often, as you would expect, and they say things like, geez, every time I turn around, there's a copay. Well, yes, and then we have to gently remind them that in many cases, they've not paid monthly premium for the better part of 10 or 15 years. That's a long time. So you have to plan.
Okay.
Conversely, 10 or 15 years later, if you're in a supplement, you're paying a lot of money, for sure.
Because it's going up.
Exactly. About 5% a year. We're now starting to see that percentage increase a little bit. I'm not sure if that was an isolated incident. I'm not sure if it's a response to the virus or it's just because everything else is inflated right now. I don't know. I don't know. A little too soon to tell.
Okay.
If someone is drawing Social Security, they automatically receive a Medicare card. It's dated logic given the new laws, but the reason for that is the assumption is if you're drawing Social Security, you're likely not working and therefore probably don't have health insurance. Otherwise, people have to physically apply for Medicare. It doesn't happen automatically. I, as a courtesy, started walking people through the Medicare application online a number of years ago because it's a 10-minute phone call versus hours at Social Security that you won't get back. And there are some questions that people were answering intuitively that only proved to be the wrong answers, and we were having to start all over again, and it just got to be a mess. So one day I thought, well, this is silly. I'm just going to start walking people through it just because it's that much easier. Many years ago, you may or may not remember this, but many years ago, Social Security sent out a mass communication to the entire country encouraging everyone to establish online accounts because they want to stop sending out those paper statements each year. Yeah. Now, in the midst of the Medicare application, at one point, you're prompted to log in with that username and password that you created for Social Security. That has to be in place for me to be able to help the online process. Otherwise, you have to call Social Security and make an appointment. Some are doing phone calls, some are letting you come in, but they tend to schedule way out in the future. So if you haven't already done so, I would encourage you to set up those accounts. You just go to ssa.gov. In the upper right-hand corner of the homepage, you'll see the icon that says sign in, sign up. You're not signing up for Social Security. You're merely creating a My Social Security account. And then from that point forward, after you've applied for Medicare, you can actually use that Social Security account to monitor the progress of your Medicare application. It's a pretty useful tool for sure.
It's a pretty good website too.
Yeah, it is. It absolutely is. So let's talk about options and costs. As we've already discussed, original Medicare Part A and B, Part B is where the premium is $170.10 per month. That's everybody's baseline. If someone were retiring today, looking at a Medicare supplement, on average, this could be a little high, could be a little low. The monthly premium for a Plan G supplement, which is the industry standard today, is about $133 a month. Because drug coverage is not built into a supplement, and because most people want to avoid a future penalty if they don't elect Part D when they're first eligible, the national average premium associated with prescription plan today is about $33 a month. So in that case, your monthly premium between Part B, the supplement, and your prescription plan is $336 and change.
And this can really go up for people that are in that tiering of the IRMA, the Medicare premium.
Yes, yes.
And it also affects Part D as well, as far as the cost.
Right. That's a very good point. Yes. I'm often of all of the advisors here, I tend to be the one that has the IRMA conversation more often than anybody else. And it's often a surprise to people when they find out that no good deed goes unpunished. You work hard and you make a decent living, and then you get penalized for it on the back end.
Right.
But yes, that can be a very, very big cost driver for people because they've fallen into a higher income bracket and are paying more for Part B, and thus the assessment on Part D. And that's been very confusing. People confuse it as premium. It is not.
Right.
It's an assessment. It's not coverage. It's not premium. If you're in a Part D plan of $33.19 a month in premium and you fall into IRMA and the corresponding Part D assessment is $70, you pay that on top of the $33.
Yeah.
It can get rather pricey.
Yep.
On the Advantage side, if you fall into a higher income bracket, you will also pay more for Part B, but typically you're not paying additional premium for your plan, meaning for the medical and or the prescription portion. If you elect a Medicare Advantage plan that has drug coverage, and most of them do, and you fall into the higher income bracket with the IRMA assessment for D, as in David, you're going to pay that. Even though you're not paying premium, you're still going to pay that assessment.
Yeah.
So in closing, just to describe how we typically work with our clients, let's use one of you as an example. You might contact me down the road and reference that you attended this particular seminar. And the first thing we do is vet your situation to get a better sense of what your circumstances are, so we're better equipped to help you take the next step. Assuming you do need to move to Medicare and need assistance applying, then that would be the first thing that we would schedule to get that 10-minute phone call on the calendar to get your Medicare application squared away. And then the next step would be for me to gather authorization, or I shouldn't say gather, to get an authorization from you, which is a Medicare regulation. Though reasonable people would agree that calling us is giving us permission to speak, the government sees it differently. So if someone calls me to make an appointment, I have to explain that I need to get authorization first. I secure that, and then once we book an appointment, I will then request additional information regarding physicians and prescriptions and all of that, which helps me do research in the background, so that when we do meet, whether it's in the office or by phone, we can hit the ground running. And then we talk about coverage options. We take care of getting people enrolled in whatever they choose is best for them. We're available throughout the policy year should our clients have any questions. And then our heavy lift, which is looming, is open enrollment in the fall, when we help our clients make any necessary changes to their coverage.
And that starts October 15th, correct?
Yes, unofficially October 1st. That's when
Okay.
data is first available, but we can't do anything physically until October 15th.
Okay.
But for instance, Medicare releases all of the Part D data on October 1. So at least we have some sense of what we're dealing with. So we try to use that 2-week period as best as we can to mitigate as much as we can.
Oh, yeah. Yeah. Makes sense. Okay. Well, that's wonderful.
You can just go through that, Eric. That's something that we share with people when we're doing actual in-person seminars.
Okay. Well, thank you, Kerry. This has been great. I think, Eric, we might be able to turn off the recording and then see if there are any questions. But do you have any closing comments, Kerry, or any thoughts?
Just for those of you who might be rapidly approaching eligibility, just use that 3-month window as best you can. I'm always available for questions. I understand that even in this forum, not everybody's comfortable posing questions. Feel free to call me. If you call that number on the screen and plug in that extension number, it will ultimately go to my cell phone, but I will also give you my cell phone number as just a direct dial, which is 614-565-0226. I'm happy to answer questions because I know how noisy it is, I promise.
Well, thank you. That's a
Welcome.
great help. Thank you very much.
Sure. Happy to help.